So for low back pain, what I'm usually looking for in the objective assessment is mainly what they're not loading, and in particular the subjective history is going to give me or kind of direct me really in where I'm paying a little bit more attention than other places. Obviously we don't want to bias kind of that, or we don't want to be almost looking for something. I think that's really important. But your bog standard movements, what I really teach in my mentorship is understanding the why you're doing something. So if you're touching your toes and you get pain at the start of the movement versus the end versus the way back up, that's given us a lot of good information that we can clinically reason. So simple movements, but understanding the why behind, or maybe what's contributing to that movement, or what should be doing this job, or what particular parts of the movement, I think it's very important to be able to clinically reason that. So again, it all comes down to me for clinical reasoning in the objective assessment. Now, I'm also going to be releasing a video where I'm going to break this down. I'm going to show you what I mean with the toe touch in a few days' time. So if you haven't picked up the Diaphragm PDF, if you go get that, then in a few days' time, you'll be getting an email from me actually showing you a step-by-step video of how to apply this information in the real world. So make sure, I think it's on the link in my bio, make sure you pick that up, and I'll get you that video where I'll actually show you what I mean in terms of which tissues are contributing, or certainly clinically reasoning and making a bit more of an educated working hypothesis. This is a really good question, and this is another one I'm going to put out a video of the slouch exercise and exactly what I'm trying to achieve with that exercise. So the beauty of that exercise is we want to put the person in a position where they have no option but to tolerate loading preferentially through the lead leg that they're loading on. Okay, now something magical happens when you relax the back is when you actually let the back to let go, all the load, or certainly more load, goes through that leg. Okay, so a lot of people, when you try to load a limb or get load through certain parts of a tissue, you'll see all these cheats happening where they're extending their neck, they're elevating the rib cage, they're taking some of that load through the lower back. From my experience, when we relax the rib cage, when we get the neck to relax, then they've got no choice but to tolerate the load. Now, there's quite a few things you need to get right with that exercise. So again, there's loads of ways that your nervous system will try work around this, where if you don't want to load certain tissues, it's phenomenal how the nervous system will just figure out ways to stop you loading this. And this is really where it all boils down to the step-by-step system. And if you don't have the athlete at the right progression at the right time, just like with that exercise I teach in a return to play, you will not be able to out-cue or out-coach that movement, because they're just not ready to it. If you do the heavy work in the first couple of sessions, earn the right to progress to standing, then that exercise becomes very, very easy. If if you do it too quickly, you won't be able to coach that exercise well, because the athlete's not ready for it. The nervous system will always find a way. That's certainly my experience with it. For Achilles ruptures, I'll be honest, I don't have anything off the top of my head. Had a few over the years, but I've always followed the surgeon's protocols early doors. And then it sounds boring, and I've had this question from mentorship therapists, but once you get out of that first few weeks and months, well, probably months in this case, then all you're trying to do then is you're trying to develop athleticism. So a lot of the progressions you're going to do, they're going to be the same anyway, but you're just going to have to be a little bit particular about what movements are maybe going to stress certain tissues more. So for instance, with an Achilles, that's something where I'd actually be doing a lot of backward stuff. Okay, so we do a lot of kind of forward hops and progressions and various exercises like hamstrings and stuff like that. That's one where I'd actually be doing a lot of my progressions, but I'd be doing them backwards. That's kind of how I think about the body. A really good question about tennis elbow, and we had one of these in actually our mentorship Facebook group the other night. And the one thing I would say about tennis elbows is quite interesting is that's one where I really work hard on actually getting the symptoms. Now I know I'm a big one of like, oh, don't just treat the symptoms, but that's actually one there where I feel I need to get control of the symptoms before we can really start to work on the other 80% of what's maybe not doing its job. But a big one again, tennis elbow, I'm looking at the wrist flexors, and again a big one for me is what's happening at bicep, tricep. Can those tissues co-contract at the elbow? Can the deltoid do its job? So again, is maybe the elbow joint or the extensors absorbing all the load because the nervous system's not happy to tolerate load either above or below it. So flexors, bicep, tricep, deltoid as well, but that's one where really good question. I definitely like to get the symptoms under control first with whatever you use. Lymphedema with the lower legs, tricky one. I've had quite a few like persistent pain cases that spring to mind that I've definitely been able to have. They wouldn't be necessarily coming in just for that, but it would be kind of an effect. And my approach to that would be very, very simple, and it's boring, but I would literally try to get everything moving from the pelvic floor to the diaphragm to the organs, just to almost use that as a good pumping system to get the lymphatic system, give the best possible chance to work. Then I'll be thinking about, okay, if there's any kind of restrictions in movement, any protective tone anywhere in the body, is that influencing the lymphatic system? So a bit like your nervous system, is there anything that's maybe stopping the nerves from mobilizing? That's the way I would be thinking about this. Now it is a little bit hard, to give you evidence for that and stuff like that. So that's just my clinical experiences. But once we've got everything moving, and especially get that diaphragm and pelvic floor moving, all the organs moving, I've noticed, and again I had a patient last week. Again, the lymphatics just tend to respond well to that. Don't ask me the exact mechanism. I don't know. As I said, I don't particularly have a strong interest to go down a rabbit hole and study all that stuff. But for me, without trying to get overwhelmed, I just keep it simple, see what I see, treat what I see, gives the body back an ability to tolerate the load, get things moving, and very often these things would sort themselves out as well. So I'm sure there's some mechanisms at play there, but I'm not going to bullshit you or lie to you. That's not my area of expertise. Yeah, really good question. So again, slouching, when we slouch, what's going to happen is our rib cage is going to depress and hopefully get a little bit of retraction. So when we depress our rib cage and retract, our diaphragm is going to come up under our rib cage in a dome shape. So from my experience, a lot of athletes, when they're stressed, when they've got increased load, at the end of a conditioning session, when they're just trying to get through the session, we all tend to go towards this extension-based posture. Now, whether that's a whole host of things, whether that's generally the diaphragm tightening, whether we're hyperventilating, so again, we're getting too much air in, not enough air out. Again, we don't have that opportunity to fully exhale, fully lengthen the diaphragm. So I see that with a lot of people with persistent pain as well that I treat, where they're very short of breath, they talk really fast. That's another sign. And so what we're trying to do when we get these people slouching is essentially we're trying to hold or sustain that ability of that diaphragm to lengthen. So again, when you go to touch your toes, one of the first things you have to do is reach your fingertips to your toes. So when you reach your fingertips to your toes, you're going to protract the shoulder blades. Okay, when you finish protracting the shoulder blades, as you continue to reach, your rib cage is almost going to go in the opposite direction. So when your rib cage goes in the opposite direction, that's going to be the retraction of your rib cage. Okay, when your rib cage comes back, that's going to be your internal obliques that are going to pull your rib cage back. And then the beauty of that is when you get the rib cage to retract, your iliocostalis is going to be able to relax. Okay, if you get your iliocostalis to lengthen or let go, That's a big muscle that I work a lot with persistent pain patients who are sat up straight and rigid and almost braced all day long. So when we can get you to slouch with a good retraction of the rib cage, we get the diaphragm to stretch. Obviously, we're going to mobilize that pelvic floor, but as well we give the low back muscles a chance to actually relax. Okay, so again, the analogy I'll use, and again we were talking about this in the mentorship Facebook group just the other day, who looks more relaxed, where I'm sat up straight like that all day, that look weird in the camera, where I'm sat up straight like this all day, okay, or somebody who's just a little bit more laid back. Okay, so that's an analogy I'll use with somebody who, actually my daughter's bedroom here, just trying to get a bit of peace and quiet, but who looks more relaxed there? Someone who's bolt upright, or someone who's a little bit slouched? Now we don't want to go into the other extreme of slouched, okay, but we certainly want to get an ability to slouch and an ability to straighten. And certainly again, with people with extension based pain, so just to recap that, with someone with extension based pain, we'd actually want them to elevate the rib cage. So again, protract and elevate the rib cage. So it's not all about slouching, don't get me wrong. And again, that's something, it's not all about being able to stretch the diaphragm. For a lot of people, it's just about being able to get that rib cage moving. And one of the restrictions, or one of the things that stop that rib cage going through full range of motion, will be that diaphragm. Because again, if you have a sensitized respiratory system, a lot of these people, they don't have an ability to utilize the hamstrings of the torso, again the diaphragm, through a full range of motion. So just like when you go to touch your toes, and again, I don't know if there's any link between hamstrings and diaphragms, but when you go to touch your toes for the first time in a while, your hamstrings will scream at you. Then you desensitize that feeling, you get a little bit more range. And that's very much like when we force the exhalation and when we pause, our nervous system gets used to that ability to lengthen the diaphragm. And when we have a good exhalation, there's a lot of good things happening there. So when we pause at the end of an exhalation, we've got a good length-tension relationship between our obliques, our low back muscles have a chance to relax a little bit. We're in rest and digest, okay? So our heart rate goes down with an exhalation, and it makes sense, isn't it? When you relax, you go, okay? Again, that kind of sighing action, the whole body follows, okay? Whereas when someone's on high alert and rigid, that's more inhalation, okay? So, or certainly that elevation of the rib cage, I should say, would probably be a more accurate term. So the exhalation, we tend to get that rib cage to depress, we get the diaphragm to stretch. So when the diaphragm's stretched, there's a lot of good things happening, but most importantly, we get a lot of variability in the breath and in movement. So a lot of these people that are hyperventilating, if you think about it, there's not a whole lot of variability there. And not also, it's interesting when we look at this on a higher level, in their thoughts, in their mind, in their ability, in their mood, there's not a whole lot of variability there. When we get someone and we can disrupt that, and we can get them to exhale for a long length of time, the beauty of that exercise, besides all the physical stuff that's going on, is we're interrupting that pattern. We're changing their breathing variability, we're going to change their heart rate variability, and hopefully then we're also going to change their mood as well. Okay, because we just break that cycle. And again, a lot of people, we'll do a lot of these exercises with them, they'll sleep through the night for the first time in a long time. It's really powerful, but it takes work, it takes practice. It's not as simple as doing just what I told you. You have to understand the environments that the person's in. But the most important thing is we understand what's driving the respiratory system, or what's driving the nervous system's maybe tone, or forcing the person to behave like this just to live life. And if we can get to that level, that's the golden trail for me, where we look at the person rather than just becoming, obsessed with a few exercises that, we can change movement quite quickly with them, and they're cool, and we get excited about them, and I get excited about them, and we almost get addicted to these quick changes. But the most important thing is we strive to find what's driving this in itself, because the diaphragm isn't the true cause. The diaphragm's reacting to something else, and that's the thing where you're not going to find a cookie cutter approach, because it's going to be specific to the person. And that's why we always start at the subjective assessment.